Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bauter and Dan Schwester here with you. Danny, today we're going to look at a study that comes out of Finland that talks about the optimal blood pressure in resuscitation from cardiac arrest, which this kind of gives us a little bit more information from the previous data set. So a variable I want to throw out here is this was done by a primarily helicopter EMS service. So it's a little bit different than what you'll see in the actual field. Stuff that we love here, 3,029 post-resuscitation cases, 1,861 received vasoactive medication, 1,665 had variables that were recorded and were included in the analysis. What they found essentially was in resuscitation, what is the best blood pressure for outcomes? Normotension between 100 and 140 millimeters of mercury was associated with lower mortality compared to hypo and hypertensive patients. They did this study to be considered for a basis for future prospective trials. Dan, this kind of throws a wrench in what we knew previously. We were talking about permissive hypotension for a long time. And now it looks like maybe just keeping things normal might be the best way to stay normal.
Yeah, absolutely. I love this study. I love what they did. I have gone through my whole career trying to figure out, hey, what's a good blood pressure to keep these people at? And all the times I've asked that question, we come up with, hey, any blood pressure is a good blood pressure. They were dead. Granted, but if we're thinking chess, not checkers, think about the damage to organs. Think about the damage to perfusion that happens with that really low flow state. This is telling us that we need to target higher than maybe we think because we need to perfuse organs. We need to perfuse the brain. They need more because from me reading it, my guess is, we need to get rid of waste products. You need to do that aerobic metabolism, and they need a good blood pressure to be able to get that blood flow. And this is telling us right now, keep these patients normotensive. Even if they're a little low, even if they're under 90, get them up. This is where you want them to be. And this has a significant impact on practice because now I'm going to look at my post cardiac arrest ROSC patients. And, in the past, I looked at an 80 blood pressure, 80 over 40, not, 85 over 60. Hey, we're doing great. Maybe we're not. We need to consider that. Now I'm going to start thinking, ooh, normotensive is better. Maybe a whisper of a vasopressor, maybe a little bit more of epinephrine will get them where they need to be and will keep those kidneys safe, keep that liver safe, keep that brain safe.
Yeah, and I think we spent a lot of time talking about cerebral perfusion, coronary perfusion. Obviously, both are vitally important when we're resuscitating somebody, but I think in EMS, because we focus so much on the emergency, on the what's happening right now, we don't necessarily tend to think about what's going to happen down the road, right?
I agree with that 100%.
We can give a bunch of vasopressors, and then as we're doing that, we're also vasoconstricting their kidneys. So, are we causing renal damage and azotemia, 45 days down the road? So what I like about this is it feels like it's almost like a lot of things in medicine kind of stand to reason, right? And I've said before that everything in medicine makes sense. It's just a matter of at what level they make sense. But here it's interesting to me that we're having the conversation of after someone becomes unstable, bringing their vitals back to a stable level will keep them stable. It feels like that should stand to reason. But after all this time where it's kind of like, just get them to the hospital alive, right? What's your blood pressure? It doesn't matter. Positive, right? Good radial pulse, something. Where I kind of like that they're taking the time in this data set to say, look, you might actually want to focus in when you're giving pressors, right? And we've talked previously, we've had plenty of episodes on what pressor is best to use, whether you're using, it doesn't matter if you're using norepinephrine or, neosynephrine, whatever.
Short term, no.
Right. It doesn't really matter, but you want to get their pressure to their physiologic norm. And that might be now what's going to happen after this paper is so, are we, what's the best pressor to give? Do we need to give fluid? Is fluid going to cause overload? How do we, so what worries me with data sets like these, and I want to shout out Arno Niiranen, who was the principal author of this paper. What tends to happen with papers like this is, we have this 3,000 sample data set. Here are the people, 100 to 140 tends to improve outcomes. What I worry is going to happen is that data is going to come out and say like, nah, it's 90. See, because it's in our data set, it said 90. And this paper feels like it feels like the very European approach where it's like, hey, maybe we could do this a little bit better and then things could improve and then we make everybody better. What do you say? And I worry that our sort of Western ethos is gonna be like, no, we do it the best way and we've always done it the best way.
Well, hubris is always a part of medicine. We need to tamp that down as much as possible. And if you're one of these people that sit around and say, "I know everything. I'm good at everything. I don't need to pay attention to this because I'm doing it right." You might not.
Right.
This is what I love about Journal Club. This is what I love about learning different things is, hey, wow, maybe I wasn't doing it correctly, but now I have this opportunity to
Mhm.
do better for my patients and they might see a survival benefit from it. I want to see this data replicated. I'd love to see it for a ground EMS unit. I would love to take the Finnish idea and their design of their paper. And I would really love to see a major American city or London or
Yeah.
somebody like that, like take this and run with it. And let's see if we can replicate it because this is actually a really interesting thing. And again, like I said, I've been in this a while. I've always thought and I've always been trained any blood pressure post-ROSC is good. Maybe it's not.
Yeah.
Maybe we need to get them normotensive. And once we get them normotensive, we titrate it to where they're at. It might mean sitting on scene a little longer. It might mean putting more effort into what we're doing post resuscitation. We've already seen data that shows that that's important. This data is showing it's even more important.
No, and I think that's right. And, here where, and again, we spend so much time just saying like, like any perfusion is better than no perfusion, which is true. But, here, and again, this paper came out in June of 2025. So this is brand new. None of this data is going to be in the textbooks for another decade. So,
No.
as we're recording this in August of 2025, we're going to keep hearing this argument over and over again forever. But we have it here first because it's important to get this stuff out. This is out of Resuscitation, June of 2025. This is Nieranen et
Great
al. And
journal.
this is great article. Optimal pre-hospital blood pressure after cardiac arrest, 100 and 140. They don't go into what pressors are used. They just looked at what the good blood pressure was that was
I don't think it
associated with
matters.
survival. Doesn't really matter. I'm excited to see what this data is going to show.
I
Let
agree.
us know what you guys think down in the comments. Are we using blood pressure management post cardiac arrest effectively? And if we're not, what pressors would you use? We've had a bunch of people on to talk about it. We want to know your opinion. Comment down below and make sure to like and subscribe here on YouTube. Check out over on EMS.com and check out all of our work on EMS One for the news and insider analysis over there. And for the over on Ed Bauter, Dan Schwester, we'll talk to you all next time.